students. Today class is about EDIC Part 1, Fluid Electrolyte, which would be conducted by Dr. Manmohan Bose. He's a consultant intensivist and in charge of AHRC hospital in Ranchi. His area of interest is in neurocritical care endocrine emergencies.
Good evening all. I'm Dr. Manmohan. Glad to be here. This will be a discussion thing. So you have to answer, you have to ask the questions. So don't think that I'll just read the questions and answer and just read the explanation. So before going to the answer, I'll be asking you why not answer A, why not answer B. That's the way I do it. Let's start. So this the previous lecture was about theory covered regarding the electrolytes and fluids. More of it is electrolytes. So for EDIC 1, electrolytes are very important. So be it sodium, potassium, calcium, magnesium, phosphorus. This all 5 electrolytes are very important. If you ask me among 5, which are the favorite for EDIC 1, it's a sodium and calcium. There will be 1 or 2 questions for sure out of 100 questions regarding the electrolytes, some way or other way. Okay, either a straightforward question or indirect question, maybe either in A type or in K type. If it is in K type, there will be single question about just one electrolyte, or there will be options regarding particular electrolyte arrangement. So electrolytes, you need to be very thorough. So first thing, it is important for individual electrolyte abnormality, as well as it is important for ABG calculation, ABG for anion gap and osmolar gap calculation. So please don't ignore this. And as we practice critical care, we do see electrolytes reports day-to-day basis. We do correct electrolytes day-to-day basis. So this part, though it is not ignored one, but I would say though we do see it on regular basis, people don't give much of importance while preparing for the exam. But practicing electrolytes management versus theoretical theory about the electrolytes are a bit different. You need to know a bit more regarding the electrolyte correction and electrolyte causes that we don't usually use in practice. So that's why I'm trying to convince you guys that you need to know few specific points regarding electrolytes theory. So I would try to cover maximum theory and while discussing those answers regarding those particular electrolytes, I would try to cover the other options also, so that in one question we would try to solve 2 or 3 questions. That's the goal. So I have taken some 26-27 questions. So let's begin. If I am taking extra time, you can ask me to move forward. I can go ahead and we'll try to cover up it in 90 to 100 minutes. Okay, let's start. So first section is about A type, and second half is about K type. So how many of you know difference between A and K? Everybody knows about A and K difference? A type and K type? All of you are aware of difference between A type and K type, right? The marking system for A type and K type. I'm not seeing any response. Okay, let's start. So type A, we'll start with the type A. Type A, there will be 5 options. You have to choose one most correct answer among the 5. And if you get it correct, you'll get 1 mark. If you don't get it correct, you'll get a 0 mark. There is no negative marking. It's regarding the exam. So let's start. A 68-year-old man has been brought with a history of collapse several hours ago. He was found to be hypothermic at 32 degrees centigrade. His creatine kinase was quite high, 9,000. His potassium was 5.1 and urea was 22 millimoles. Creatine was raised 310. The most important initial treatment should be, what would be the most important initial treatment? Answers from the candidate.
Intravenous infusion of warm crystalloids.
Okay.
Yeah.
Any other answer? All of you A?
Yes, sir.
Okay, good. Correct. So that's the right answer. Very good. So general crystallite should be, and because he is hypothermic, so warm crystallite should be the choice here. Okay, active warming is important, but before giving intravenous fluids, if you try to actively warm him, that will actually further worsen the hypotension because of the vasodilation. his potassium is though above the normal range. Okay, his potassium was somewhere 5.1, but that doesn't require urgent dialysis. If you give him fluids, maybe that will correct his potassium as well. Okay, you'll be wary of giving IV fluids which are high content of potassium, like ringer lactate and others. So you'll be careful about giving those ringer lactate. You'll be preferred fluid of choice will be normal saline or balanced crystalloids. Okay, any doubt regarding this?
No, sir.
Okay. Second question. A 74-year-old male, history of diarrhea and vomiting, confused, complaining of lethargy, tingling in his hands and feet. While being transferred to the hospital, he suffered a brief self-terminating seizures. On arrival, his examination shows muscle weakness with positive 𝐄𝐥𝐿 signs, process sign, ECG shows ST depression, T wave shows flattening of U waves, QTC was prolonged. Which is the primary electrolyte disturbance? Can explain all these findings.
A.
Hypokalemia. Okay.
Hypocalcemia.
Okay,
No,
both
sir.
are right.
Hypomagnesemia will explain all of them. Right?
Yes, correct. Super. Good. See, the 𝐄𝐥𝐿 signs and process sign, if it is just that's the thing mentioned in this question stem, then you can go ahead with the hypocalcemia. But there are T waves flattening and U waves plus QTC prolongation. So T wave flattening and U waves and ST depression, all these are signs of hypokalemia. So the signs of hypokalemia and hypocalcemia is both are there. So there is history of diarrhea, vomiting, lethargy. Okay, all these things will actually fit in hypomagnesemia. So before correcting hypokalemia, before correcting hypomagnesemia, if you try to correct potassium and calcium before correcting a magnesium, it won't help much. You have to give magnesium first, and then simultaneously, if you find calcium and potassium low, you will correct both. Okay, so but the primary, which one electrolyte explain all the abnormalities, is the magnesium. The answer is E, magnesium. Magnesium is essential mineral, important for bone mineralization, muscle relaxation, neurotransmission. So hypomagnesemia can affect any system in your body. It is so important. Ignored electrolyte, we don't give so much importance to magnesium on day-to-day basis, but it is important. If you find any patient who is getting deteriorated for without any reason, don't just get away by checking sodium, potassium. Please focus on magnesium also. So causes of hypomagnesemia can be polyuria, diarrhea, prolonged vomiting, large nasogastric aspirate, inadequate intake like a starvation, parental nutrition. Clinical features, as I said, it can affect central nervous system, can lead to confusion, irritability, seizures. It can affect CVS, can lead to arrhythmias. The hypocalcemia, hypokalemia will be resistant if you don't correct magnesium first. So prior to correcting those calcium and potassium, you need to correct magnesium. The combination of signs and symptoms of hypocalcemia, hypokalemia are suggestive that the problem is magnesium. So correct magnesium with IV correction. Okay, question number 3. A 47-year-old gentleman admitted to the hospital for a long time. He develops hypophosphatemia, hypomagnesemia, and hypokalemia following the introduction of enteral nutrition. What is the most appropriate next management step? Answer, please.
E, sir, potassium replacement and continue enteral feeding, allow shift of electrolytes from total body stores to renal liquid.
Okay, any
Agree.
other?
E is right, I'm agree as well.
B for Bombay.
E is.
Okay, any other answer? So you want to start, so the first candidate answer E answer, I heard that. Second candidate answered B for Bombay. He wants to replace the electrolytes and stop internal feeding. Any other answer? Okay, there are answers on the chat. Okay, did anybody answer C? You can unmute yourself rather than let me go on chat. You can unmute and say the answer. That will be better for me. Madhvi Bhumiti has answered C. Huh?
We will make electrolyte replacement C and we will reduce enteral feeding.
Super, very good. So that was That's the right answer. So you don't stop the enteral feeding. Okay, the option B is wrong. You don't stop the feeding. Okay, and option A is also wrong. You don't continue the same amount of enteral fluid. So why all these electrolytes will get decrease in your intravascular compartment? This patient diagnosis is what? First, tell me the diagnosis of this patient.
Refeeding syndrome.
Correct. So as you said, it is a refeeding syndrome. So what do you think? In refeeding syndrome, there will be only hypocalcemia? In the question itself, I have mentioned there is a hypomagnesemia, hypophosphatemia. So you won't bother about just the potassium alone. You have to replace the phosphorus, you have to replace the magnesium as well, right? So E is wrong, though they have mentioned the mechanism in option E, but the correcting of just potassium alone is not enough. Okay, so you have to correct all the electrolytes, and while doing that, you need to reduce the feed, not containing the same amount or not to stop the feed. You need to continue the feed, but before doing that, you need to reduce the feed and correct the electrolytes, all the electrolytes, whether it is a phosphorus, calcium, magnesium, or potassium. Understood?
Yes, sir.
Clear, thank you.
Okay, good. Okay, so that's what the diagnosis was, refeeding syndrome. See, before going to answer, I'm trying to cover the explanation as much as on the options itself. So my whole funda, even if they have some modification in this question, see the EDIC, what strategy we have to use. You don't have to read much of theory. The theory topics are more or less same. Okay, it will be always about hypokalemia or hypercalcemia. It will be always about hypomagnesemia or hypermagnesemia, but the question stem will be different. So by ruling out other option, why other options are not right, by doing that you will be considering other answers also. So even if the question stem is different, you will be able to answer. So I'm not going to explanation directly, I'm just discussing the option and then I'm going to discussion. So explanation, you can read it later on also by watching the recording, but here we want to discuss it. So that's why I'm discussing the answer in the question itself. Okay, so it is a refeeding syndrome, and why it happens? Because when you malnourished patient, when you feed them more than, even if it's a normal calorie requirement, okay, you don't need to feed them with a supranormal calorie requirement. Normal calorie requirement, even if you try to feed them, there will be insulin surge, and whenever there is insulin surge, it will push your electrolytes from intravascular compartment to intracellular compartment, because when he was malnourished or nutritionally depleted, there was a electrolyte shift from intracellular compartment to intravascular compartment. So intracellular, already all electrolytes are depleted. So whenever there is insulin surge, these electrolytes will be shifted to intracellular compartment. So there is sudden drop of electrolytes in intravascular compartment. So that can lead to arrhythmia, can lead to multi-system involvement. As I said, magnesium can affect any system, so even that can lead to. So that this commonly happens in surgical patients. They will be NPO for few days, then they go undergo, before the surgery, before coming to the hospital, they'll be NPO because of the abdominal pain and distension, perforation peritonitis. Let's take a perforation peritonitis. So before getting admitted, he was not taking feed for few days, admitted, operated, post-op he was NPO for few days, and then day 7, day 8, you start him on internal or parenteral nutrition. So 7-8 days is good enough to cause electrolyte disturbance. So when you start the feeding at that point of time, the patient is at risk of refeeding syndrome. So you need to be conscious about electrolytes. So you need to recheck your electrolytes every 24 to 48 hours and be sure that you are not causing any electrolyte abnormality because of the refeeding. Okay.
Sir, you have given E as the answer.
I'm so sorry. Is it so? One second. Huh? No, I'm sorry. The answer should be it should be B. Okay. No, sorry, B, not B. It should be C. The answer is C. Okay. I don't know. It was a mistake. Sorry for that. The answer is C here. Is it clear to all of you? It's a typing error from my end. I'll just correct it.
Clear.
Yes.
It should be C. Okay. You don't stop, you don't correct the potassium alone, you reduce the feed and you correct all the electrolytes. Okay, sorry for that error. Thank you for correcting me. Next question. A 76-year-old lady admitted with a confused state. Her GCS is 9. She is tachycardic, hypotensive. Her mucous membranes are dry. She's maintaining but she's maintaining a good urine output. Her sodium is 177, potassium is low, 2.8. Glucose is on the higher side. Osmolarity 310. Urine analysis show osmolarity of 272. Once the patient stabilized, her serum sodium returned to normal level. Then after that, water deprivation test was performed. Prior to the test, her urine osmolarity was 275. After water deprivation, her urine osmolarity was 274. So before water deprivation, it was 275. After water deprivation, it was 274 in urine osmolarity. So there is not much of change. Okay. After the administration of desmopressin, urine osmolarity stayed more or less same. What is the diagnosis?
Nephrogenic DI.
Okay. Any other answer? Did everybody understood the question? This question is all about hypernatremia, hypokalemia, okay, with the high serum osmolarity and with a low urine osmolarity. Okay. Are you guys getting me? You need to first find out what are the hidden things given in the question. So here, the important findings for me: GCS is low, sodium is high, potassium is low, serum osmolarity is on higher side, urine osmolarity is on lower side, and it is not getting changed with the water deprivation state, and it is not getting changed even after giving desmopressin. So when it is the urine osmolarity, yeah.
Answer is E, hypodipsia.
Hypodipsia. Okay. Good. Any other answer? Okay, let me complete it. Okay, so when you see hypernatremia, how will you differentiate whether it is DI or psychogenic polydipsia? What happens in psychogenic polydipsia or hypodipsia? So hypodipsia is opposite of polydipsia. Okay. So she is drinking less water. So what will happen when you do water deprivation state? How will you differentiate between DI and psychogenic polydipsia? When you perform water deprivation state in psychogenic polydipsia, the urine osmolarity will go up. Okay. Here, there was no change in urine osmolarity. Prior to the test and even after the test, urine osmolarity stayed same in water deprivation state. So it is a case of DI. So now you have to differentiate whether it is a central DI or nephrogenic DI. How will you differentiate between central DI and nephrogenic DI? If it is central DI, if you give desmopressin, the DI will respond. The urine osmolarity will rise after giving desmopressin. Did urine osmolarity increase here after giving desmopressin here in this question?
No, sir.
No. So central DI is ruled out. It is a nephrogenic DI. There won't be any response to desmopressin in nephrogenic DI because it is a resistant to vasopressin or desmopressin. So the answer here is a nephrogenic diabetes insipidus. That's the answer. Okay. Yeah. C. Correct answer is C. So what are the signs here? We found it was a hypovolemic hypernatremia. When the hypovolemia is present, you should check the. In case of hypovolemia, what do you see? You see the concentrated urine. Don't you see that? So in case of concentrated urine, the urine osmolarity should be more than 800. Here the urine osmolarity was just 270 or 275. So after confirming the polyuria, water deprivation test was confirmed, which ruled out our polydipsia and which went into the favor of DI. So how did we differentiate between central DI and nephrogenic DI? By performing a desmopressin challenge test. Okay.
Sir, one question. Polydipsia will be characterized by hyponatremia, no, sir?
Yes,
Or
yes. So that's why there is no option of polydipsia here. It was hypodipsia. It was a tricky, but this case was, so psychogenic polydipsia will cause what? You are drinking more and more of free water, right? So it will dilute your sodium. So that will lead to hyponatremia, not hypernatremia. Okay. Hello.
Yes, sir. Yes.
Yeah, but that will lead to excess. Yeah. That will lead to excess urine also. So that will cause polyuria as well. Okay, so if the polyuria is exceeding a polydipsia, in that case, the sodium can go here and there. In that case, that's why water deprivation test is important. How will you differentiate between DI and polydipsia? It is always water deprivation test. Okay.
Okay, sir.
Thank you. Next question. 49-year-old drug user admitted in a drowsy state. He has a clinical evidence of compartment syndrome in the left leg. He underwent fasciotomy. His ABG showed pH of 7.23, base excess of -12, potassium was high, 6.1. His potassium was 4.4 in emergency department. Okay, now it is 6.1. On admission, it was 4.4. His current blood pressure is 100/40, not requiring any inotropic support. His urine output has been poor, approximately 10 to 15 ml per hour since admission. He had already received 5 liters of Electrolyte since admission 16 hours earlier. So in last 16 hours, he already received 5 liters of fluid. His current CVP is 6. What is the most appropriate next management step?
CVVH, sir. First, A.
Okay. What about other candidates? I want everybody to involve. Whatever I am able to interpret, I think only one candidate is proactive. So even if you don't know the answer, you try to answer it. Okay. So nobody is going to reduce your mark or nobody is going to judge you that you are not able to solve these questions. Okay. These are practical questions, but you need some bit of theory into it. So other candidates, I have some, how many people?
Noradrenaline infusion.
Huh?
Ансфельджин, noradrenaline infusion.
Okay, but the blood pressure is acceptable, though the diastolic pressure is low.
Yeah, diastolic pressure is low, which means MAP will not be good enough to perfuse the kidneys.
Agree, but is it that's the only important step here? What is the diagnosis here? Somebody has said C, further fluid loading until CVP is greater than 10. No, he has already received 5 liters. First, tell me the diagnosis. This patient has compartment syndrome.
Sepsis became leading to hyperkalemia.
Sepsis. No, it is not a sepsis.
Most
More than
likely
that.
rhabdomyolysis.
Rhabdomyolysis. Very good. Superb. The same question. That's my whole goal. I'm here. There could be 2 questions instead of this. There could be a question. What is the diagnosis? They'll give 3-4 diagnosis. So the diagnosis here is a compartment syndrome led to rhabdomyolysis. Okay. Though he underwent fasciotomy, but it was quite late. So the diagnosis is rhabdomyolysis, which is causing the metabolic acidosis and hyperkalemia. So considering the hyperkalemia, because see his potassium has gone from 4.4 to 6.1 last 12 to 16 hours. So that is a worrisome thing. Okay. So mannitol. So what's the treatment, preferred treatment for rhabdomyolysis here? Already he has received good amount of fluid. So fluid is not the answer. Noradrenaline is not a wrong answer, but you have to choose the most.
Alkalinization of the urine with sodium bicarbonate.
But is that good enough? Is that
Answer
good enough?
will
Because
be
he's
A.
all, huh?
Sir, hemofiltration.
A. Answer will be A. But the
Yes.
question is the next appropriate next management step. Though it is the definite management that continuous venovenous hemofiltration, here we have given already 5 liters of crystalloid, but how we can judge that is sufficient, because CVP is low. In any kind of question, we have to we have to check it by the straight leg rising test, like that. How it
Correct.
is sufficient.
So did they give any other data regarding the fluid, whether he is adequately hydrated or not? They have given just the CVP. So can you go ahead giving
And
further
BP is
fluid
also
boluses?
low.
No, I understand, but is it good enough to give further fluid boluses by just looking at CVP?
No, sir, no.
No. Okay, that's why further boluses just giving by CVP targeting 10 is a not correct answer. Noradrenaline, yes, in some point of time I would consider, but still that is not the preferred answer. Mannitol, definitely no. Okay, alkalization, yes, if that is the first step, if it presented with a rhabdomyolysis, if that is the first step, okay, but here most appropriate step. Okay, so it is a hemodialysis, venovenous filtration. That's a correct answer.
In many cases, the answers are like that. as the question is appropriate next step, in many of the cases, the answers are like that is the immediate optimization of the central venous pressure.
No, CVP,
That is
you
the
see,
problem.
that's a newer guideline.
We
You
get
don't run behind
confused.
CVP. You have already given 5 liters of crystallite. How much of fluid you want to give?
That
16
is
hours.
yes, that is
Yeah. See, if they have not given fluid, what is the first important step? Obviously, IV fluid, be it rhabdomyolysis, be it a septic shock, or be it any other case. Okay, it's always a IV fluids. I'm not denying that step. It is always, whatever is the diagnosis, always give you. Always you go ahead with the boluses. But you see, in last 16 hours, he has received 5 liters. So still, do you want to run behind a CVP? That is my question.
And plus the urine output is also low. We will not
Low. So you need to be wary of that as well, right? So you have given adequate fluid, urine output is low, his potassium is rising trend. So this is the time to think of dialysis.
the definite management is continuous veno-venous hemofiltration. That is right.
Yeah, but that is also most appropriate next step. Okay. See, the definitive management for rhabdomyolysis has already been done. They have undertaken the taken care of compartment syndrome. Okay.
Yes,
if you
yes.
ask me what is the definitive management, they have already taken care of the cause of the rhabdomyolysis. Okay. So we are not talking about what is the we are talking about the complication of compartment syndrome which led to rhabdomyolysis, and we are trying to rectify. We have given the fluids, but still patient we were not able to rectify the problem. So now the next step is a veno-venous hemofiltration. Okay.
Okay.
Yeah, there was so this patient has rhabdomyolysis associated with the AKI, developing severe hyperkalemia and metabolic acidosis. So he has oliguria of more than 12 hours. What is the definition for oliguria?
urine output less than 0.3 ml per kg per hour for more than 12 hours.
More than 6 hours. 6 hours.
Less than what? How much ml per kg?
0.5 ml per kg.
0.5 ml per kg.
0.5 per kg. Get it. Okay, right. Yeah, so that's all. So noradrenaline may need it, but there is no evidence to support the supranormal goals. If you calculate his map will be around somewhere 65. So you don't run behind 70, 75 map. That's the reason. And having received 5 liters of IV fluids already with a minimal urine output, there is a little ground to suggest that this patient is not adequately fluid loaded. Just based that CVP is low. Just based on CVP, you don't run behind giving further IV fluid boluses. Okay, next question. All of the features of typical early rhabdomyolysis except
hyperphosphatemia.
Answer E, hyperphosphatemia.
Hyperphosphatemia. Okay, then think through it. Anybody else in the chat? Definitely not. A hyperphosphatemia is not an answer. Okay.
Hypocalcemia, sir.
Hypocalcemia. See, think. What is the question? What are the answers? What are the findings in early rhabdomyolysis? One thing is not typical of early rhabdomyolysis. Hypocalcemia, it is a finding of early rhabdomyolysis. Hyperphosphatemia, it is a finding of early rhabdomyolysis. C and E is not an answer. See, 2 are gone. What about A, B, D? Somebody has answer in the chat. Answer B. Yes, that's Sumita Ghosh. Correct. Answer B is a correct answer. Raise creatinine kinase, everybody will agree?
Yes.
Yes. Hypocalcemia, definitely. Yes, early rhabdomyolysis, there will be hypocalcemia because calcium will form a calcium phosphate and hypocalcemia will present. Hyperphosphatemia, hyperkalemia, hyperuricemia are the findings of rhabdomyolysis. Okay, so hyperphosphatemia, definitely yes. Hypocalcemia, definitely yes. Raised creatine kinase, definitely yes. So the doubt is between B and D. In urine routine, you do see blood 3+, but it is not a blood. What is it?
This myoglobin.
Myoglobin. Yes, correct. It is a myoglobinuria, not hematuria. So RBCs won't be there in a routine microscopy. Okay, though it will show blood, but there won't be any RBCs. It is actually myoglobin. Okay, correct. Going ahead. Yeah, so patient with rhabdomyolysis is present with the pigment and granule class. Myoglobinuria will cause false positive result for a blood in urine on dipstick. So you need to distinguish between myoglobin and hemoglobin by performing RBC in a urine. Okay, muscle breakdown will release the intracellular content, which will be raised creatine kinase, raised phosphate. So raised creatine kinase and hyperphosphatemia. Hypocalcemia will be there in early stage because the calcium will enter into the damaged cell and it will form a compound with a phosphate that will be calcium phosphate. In the later phase, rhabdomyolysis, as the rhabdomyolysis recovers, as the renal function recovers, this calcium will be mobilized to intravascular compartment. So the hypocalcemia can be possible. Okay, so you don't run behind the hypocalcemia in early rhabdomyolysis. You wait there, you watch, you'll correct with the fluids, you'll try to correct the other causes, you'll try to control the potassium because that is more dangerous, and then you will recheck the potassium, calcium, uric acid. The mostly calcium, the hypocalcemia will correct on its own. Sometimes it can go up to hypercalcemia. Next question. A 63-year-old male admitted in a confused state, his corrected calcium was 3.2 millimoles per liter. See, if you guys, if few of you are from India, we measure calcium in milligrams per deciliter, but EDICCM society, mostly they will give electrolytes in a millimoles per liter. So you need to be aware of the normal range for milligrams per deciliter as well as millipore pulse liter. There are only 5 electrolytes. Please be aware of those unit, both unit, milligrams per deciliter as well as millimoles per liter. So here the calcium was 3.2. He was given 3 liters of saline over 24 hours. His repeat calcium was 3.1. Mucous membrane was moist. His PTH level was suppressed. He is still confused. Which of the following is most appropriate? Next step. Most appropriate was next step. He's already received 3 liters of fluid. Answer, please.
Bisphosphonate, sir. C.
Okay. Any other?
C.
C. Okay. Why not A? Why not A? Definitely, he's still drowsy, so he still need further correction for the calcium.
Fluid
calcium
resuscitation is given, sir. Fluid resuscitation is given.
Okay, so no, A is not good enough because he still need further treatment and he has already received 3 liters of fluid. So continuing just the fluid alone won't help. So A and B is ruled out. Would you consider direct dialysis? No, D is also not an option. Loop diuretic therapy at this point of time? No. The correct answer is a bisphosphonate. Okay, at this point of time, you will consider bisphosphonate. So the initial management of hypercalcemia is always fluid rehydration. Those who are asymptomatic, like mild hypercalcemia, and those who are able to take orally, you will give them oral fluids rather than giving IV fluids. Okay, if they are conscious oriented and the calcium range is between 2.6 to 2.9, you'll manage them oral fluids. If the hypocalcemia is moderate, like 3 to 3.4, should receive IV fluid. Okay, should be rehydrated with the normal saline. If the patient who are symptomatic, even with a moderate hypercalcemia or those with a severe hypercalcemia, if the calcium level is more than 3.4, you should aggressively resuscitate them with the IV fluids. The use of furosemide. Many people get confused. See, in some books, they have mentioned first step, IV fluid, second step, furosemide, then go for bisphosphonate. But the role of furosemide is in a specific cases only. If you rehydrate them, over rehydrate them, if you give them extra fluid and they are going into fluid overload state, okay, volume overloaded patient, only in those cases there is a role for furosemide. Otherwise, the next step after fluid rehydration is always bisphosphonate. Okay, so here the use of IV furosemide should be reserved for the patient who have features of volume overload after a fluid rehydration. Sometimes calcium is not coming down, creatine is also rising trend, because where will be worry of giving bisphosphonates? In which case? Answer, I'm asking you question. In which case, here we are not mentioned creatinine value. Where will be wary of giving bisphosphonate?
Deranged renal function.
Yes, deranged renal function. If there is a AKI with a hypercalcemia, you'll be careful before giving bisphosphonate. So in that case, to correct the calcium alone, you need to consider dialysis also. Okay. Next question. In patients with suspected rhabdomyolysis, which is true? Fast. All these are common questions and we are repeating about rhabdomyolysis. Which is true? The rhabdomyolysis, tumor lysis, hyponatremia, hypernatremia. These are the questions they'll ask you somewhere other way.
Alkalinization aims to increase. Sorry, C.
Okay, C. Okay, any other answer? So D we already discussed. It is always hypocalcemia seen in the early stage. Hemodialysis doesn't require in each case. Some patients do recover with the IV fluids alone. Okay, somebody has answered C. Okay, correct. C is okay. D and E, no, nobody will go ahead with the, no, there is no question of D and E. A and B. What about, does absence of myoglobinuria will exclude the diagnosis? Sometimes you won't get myoglobinuria. Okay, so that doesn't exclude the diagnosis. So correct answer is C. Good, everybody got it right. So alkalinization of urine to increase the solubility of the Tom Hofschild protein, myoglobin complex. Okay. Rhabdomyolysis is a dissolution of striated muscle. Again, the same explanation of rhabdomyolysis, okay, which will lead to breakdown, will cause the hypocalcemia, hyperkalemia, hyperphosphatemia, hypouricemia. So aggressive fluid resuscitation. Alkalization, does it help if the urine output is sustainable, if the patient is not going into fluid overload, if the AKI is not getting worsened, you will continue the alkalization. And early stage, there will be hypocalcemia and not everybody requires hemodialysis. A 45-year-old woman presented to the emergency department with a left loin pain, diagnosed with a left side kidney stone, which passes without intervention. She was previously well. HB was 12, WBC count was 8,900, sodium was 138, potassium was 4.5, creatinine was 102, calcium was 2.9, phosphorus was 0.7. Which of the following is a most likely diagnosis? It's a pure theory question. Bit tricky, bit difficult, but if you know theory, you will get it. What do you see in the labs? There is a
hypercalcemia.
Hypercalcemia.
Hypophosphatemia.
Secondary.
Huh?
Secondary
What?
D.
Secondary hyperparathyroidism. Where do you see secondary hyperparathyroidism? What about creatinine? That's what you, yes, the first interpretation was right. Calcium is raised. Phosphorus, yes, okay, on lower side, agree. But calcium is more important. So where do you see secondary hyperthyroidism? Hyperparathyroidism.
CKD patients. So
CKD patients. So what about creatinine? Creatinine is normal here. Up to 110, it's normal. So renal function is normal here. So secondary hyperparathyroidism is not the answer. That has been ruled out.
So this is primary hyperparathyroidism.
Correct. It's a primary hyperparathyroidism. Good. Okay. This patient has a primary hyperparathyroidism. So this patient has symptomatic hypercalcemia with normal creatinine, phosphorus just below the lower normal limit. This patient fits with the primary hyperparathyroidism with a hypercalciuria leading to renal stone formation. PTH level sometime will be inappropriately normal. In primary hyperparathyroidism, you expect high parathyroid, but sometimes it will be normal as well. So normal parathyroid hormone does not rule out primary hyperparathyroidism. Be aware of that also. So treatment, if it is a primary hyperparathyroidism because of the parathyroid hyperplasia, the surgical intervention is the best option. In case of tertiary hyperparathyroidism, where the patient is unfit to undergo surgery, 𝐶𝐈 is the treatment of choice. Next question. 33-year-old woman presented with a polydipsia, polyuria. The symptoms started soon after road traffic accident 6 months ago. Her blood pressure was 120/80. no postural drop. Daily urine output was 6 to 8 liters. Blood test showed sodium of 130, potassium 3.5, urea 5.5, glucose 4.4. The plasma osmolality was 268, urine osmolality was 45. Which of the following is the most likely diagnosis? Back to sodium.
It's the other. E.
𝐷H. Okay.
Yes.
Okay. Any other option? Why do you say 𝐷H? Because she had a road traffic accident.
Yeah, history
Just-
of road traffic accident, and also this sodium is low.
Okay. But what about urine osmolality? Urine osmolality is too low.
High now, sir. In SIADH, urine should be high osmolality.
Yes, it will be urine osmolality will be high. So urine
Primary
osmolality is too.
polydipsia then.
Yes.
Hmm.
Okay. So
Primary.
it's not a DI. First of all, see, rule out the DI. It's not DI. A and B is straightforward rule out, because in DI you see hypernatremia. Okay. So A and B is not. So you need to worry about CDE. So why there will be ATN now? Okay. 6 months after the accident, patient is doing well. Urine output is, there is a polyuria, urine blood pressure was, there is no acute event of acute kidney injury that will be recovery phase of ATN. So C is also not fitting into the question stem. So you need to choose between D and E. Okay. So the answer is between D and E. So why answer E is not right? Because in SIADH, the urine osmolality will be inappropriately high. There will be those hyponatremia to save the sodium getting excreted into urine. There will be concentrated urine. So urine osmolality will be much more than 250, 300. Okay. I'm not sure about the exact value, but urine spot sodium will be high. Okay. Urine osmolality will be high. So the answer here is because of the dilutional hyponatremia, because of the excessive polydipsia, she's taking excessive water and causing polyuria. That's why the urine osmolality is low. So the answer is polydipsia, primary polydipsia. Okay. So primary polydipsia is a psychiatric disturbance that leads to fall in plasma sodium as well as the plasma osmolality with a concomitant low urine osmolality. Okay. So if this is the answer, what will the first test you will perform? We discussed that in the previous question. If the diagnosis is a primary
Water
polydipsia,
deprivation test.
yes, correct, good. Water deprivation test you will perform. Okay. And if the sodium improves, if the urine output decreases and urine osmolality improves, that will confirm your diagnosis of primary polydipsia. Very good. So DI will be won't be that, because it will increase the osmolality always the serum sodium that we already discussed. So during resolving and diuretic phase of ATN, serum sodium will automatically go high. SIADS, there will be low plasma osmolality, but the urine osmolality will be high, which is usually much greater than the plasma osmolality. So SIADS is not there. Urine spot sodium is also high in SIADS, that will be more than 20. Calcium homeostasis is dependent on the fact that, what is the correct? What is true about calcium homeostasis?
I think number A, 99 of filter calcium reabsorbed in the proximal.
Okay. 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 Any other option? Okay, correct. That's the right answer. 99% of filtered calcium will be reabsorbed in the kidneys. Why not B? Mainly the calcium will be regulated by the intestinal absorption. It does not depend on the kidneys alone. Okay. Calcitonin actually increases the excretion of the calcium. Okay. Decreased renal excretion will lead to hypercalcemia and sarcoidosis. Okay. That is not the reason for hypercalcemia and sarcoidosis. Okay. There is some other reason for hypercalcemia and sarcoidosis. Most of the serum calcium exists as a free calcium. No, most of the calcium will be in a ionized form. Okay. So if the same questions comes in a K type, you should be able to answer the same question. Because in A type, you need to choose only one answer. But in K type, even if you know one option correct, you need to see what about other 3 options, whether they are right or wrong. So you need to be sure whether they are right. That's why you need to read all the options, think through it.
Sir, most of the serum calcium exists as free calcium ions. It means the same, na, sir?
No, it is ionized. It is most of the calcium will be in ionized form in your body. Okay, it is not the free
Bound
calcium. It is
albumin, bound.
there is explanation. There is explanation. Okay, so the answer A is right. 89 to 99% of calcium will be reabsorbed. Out of that, mostly it will be absorbed in a PCT and rest up in a most of that will absorb in a PCT and 20% will the loop of Henle. Intestinal absorption is more important for the calcium regulation. For your answer, yes, the last line. Most of the calcium is bound to albumin and other anions such as phosphate and citrate. Okay, so ionized form is higher than the free calcium. Okay, and ionized form is more important for our regulation of
Most of
homeostasis.
the calcium is bound to albumin, so primarily it is the bound form.
Yeah, that's what. So what? So here that is a wrong, na? Most
Wrong.
of this is. तो वही मैं बोल रहा हूँ ना. This is wrong. That's why the answer is A is right. All other 4 are wrong.
Okay.
Did you get what I'm trying to say?
Yes.
Most what you are saying is right, but so that's why this the option E was wrong. The answer was A. Okay. Yeah. 18-year-old recovering from meningococcal septicemia treated with a high dose of cefotaxime. He had gangrene in his 4 toes, which because of that he underwent amputation. Post-operatively, he complained of flank pain. Now he's becoming drowsy. He's becoming lethargic. His blood pressure is on lower side, quite low, 90/45. His peripheries are cool. His creatinine is rising, 156. Urea is on high side, 29. Potassium is quite high, 6.7. Sodium is low, 119. Bicarbonate, lower side, acidotic, 17. His urine spot sodium is 36. Which one of the following is most likely cause of his deterioration? Too much of information, but taken from one of the EDIC questionnaire only. Okay. Think, just reread it, the question, you will get the answer. Think through it. The history is very important here. See the electrolytes, see the other signs, you'll get the answer. Somebody answered. Okay, one person has answered. Okay.
Yes, adrenal insufficiency.
Okay. Okay, 2 people. Other people? 2 candidates have answered. Do you agree? Other candidates agree to this answer? 2 candidates have answered C.
SiADH, sir, E.
See the potassium. See his blood pressure. So those who have answered adrenal insufficiency, justify your answer. Why did you say answer C? Tell me the positive findings.
Hypotension. He has hyponatremia and hypokalemia.
Correct. Good. And history. Meningococcal can cause adrenal hemorrhage. Okay. Meningococcal, it's a dreaded thing. And the lab parameters are fitting into adrenal insufficiency. Okay. And there is a metabolic acidosis also because of the hypoprophagy. So hypotension, cool peripheries, because of the hypotension, rising creatinine, and the most important, hyponatremia and hyperkalemia. Okay. So what about sugar here in this case? What will be the sugar? Will it be low or high?
Low.
Low. So same patient. So you will give fluids, you will try to correct things. What is the most important treatment for this patient? The diagnosis you got, I'm trying to get the treatment also. Most important next step.
Hydrocortisone.
Yes.
Giving steroid.
Correct. Steroid, hydrocortisone. Good, very good. Get that as well, okay? Because if the same questions comes, what is the next important step? Yes, if they have already given fluids, you will go ahead before starting NORAD and all fluids, and you will consider hydrocort. See, in septic shock and all, we give fluids, we start NORAD, we do consider vasopressin, and then we consider hydrocortisone. Okay, but here it is a clear-cut case of adrenal insufficiency. You give hydrocortisone as early as. Okay, so there is combination of hyperkalemia, hyponatremia, metabolic acidosis always suggests hypoadrenalism. Adrenal insufficiency suggests results in mineralocortical deficiency, potentially life-threatening, salt wasting. Okay, bilateral adrenal hemorrhage is possible in meningeal septicemia. Okay, this was initially described as a Waterhouse-Friderichsen syndrome. Okay, though the recent commonness cause for that is a Pseudomonas infection. All of the following are true regarding magnesium therapy in eclampsia, except all are true regarding magnesium, except.
Bu, saya boleh nggak, Dokter Lestari, boleh nggak saya minta waktu dari jam 10 sampai jam 12? Mereka saya kan sudah kemarin saya sudah ini konfirmasi sama.
Answer please. Those who are discussing, please mute yourself.
Terus 𝑭𝒂𝒓𝒛 minta.
Answer. What is the target sodium? Target magnesium. A, is it right or wrong? Is it true or false?
It's true.
True. Respiratory paralysis can occur above 7.5. Is it true or false? True. Okay, A and B, you got it. What about C? If you are not sure, okay, we are not sure about that also. You can say that.
The answer.
NMDA receptor.
Yes, very good. So if you are not sure about, rule out one by one, because you don't, if you are not able to answer in one go rule out one by one. A and B is definitely not there. Okay. Half-life, yes, you repeat magnesium in every 4 hours. So half-life of magnesium, even if you are not sure, yes, E is a possible right, true. In D, you do give bolus of 4 gram first, and then you start infusion 1 to 2 gram per hour. Okay, so A, B, D, E, you got it true. So even if you are not sure about what receptor it is, you will get the answer C by ruling out option. If you know, as many of you suggested, it acts on NMDA receptor rather than GABA receptor. So that is the answer. That is the incorrect option. So that is the answer C. Okay. Magnesium is the first line anticonvulsant to manage the seizures in eclampsia. The usual dose is 4 gram followed by 1 to 2 gram as a maintenance dose. The target will be 2 to 3.5. The therapeutic window is very narrow, so you need to monitor the serum level and be wary of the toxicity. Okay, magnesium has significant anticonvulsive activity on eclampsia, but the mechanism nobody is very sure. Okay, the proposed mechanism, yes, NMDA receptors, others suggest because of vasodilation of intracranial vessel or prostacyclin are the possible, but no proven therapy. But if you ask me the receptor, it is NMDA receptor, not the GABA. Next question: hypokalemic metabolic acidosis will most likely occur in. Okay, which of the fluid loss will cause hypokalemic metabolic acidosis? What usually happens in hypokalemia? What you do see in hypokalemia? Do you see hypokalemia related to metabolic acidosis or metabolic alkalosis?
Metabolic alkalosis.
Yes. Okay. So usually it happens hypokalemic metabolic alkalosis. But here the question is, in which case you see hypokalemic metabolic acidosis? Which fluid loss will, from which organ the fluid loss will cause hypokalemic metabolic acidosis? Stomach, vomiting.
From A and B. Answer B.
B.
Yes.
Sweat.
No. It's a colitis. Okay. Excessive loss secretions to the colon, like a diarrhea, excessive laxative abuse, will cause hypokalemic metabolic acidosis. Diarrhea patients, what do you see? You see hypokalemia as well as metabolic acidosis. Don't you see that? Okay. Excessive loss from the gastric juices can lead to, but it will lead hypokalemia, metabolic alkalosis. Other common causes of hypokalemia with metabolic acidosis, the other DD would be RTA, renal tubular acidosis, or salt wasting nephropathy. So one is this diarrhea, loss of fluid from the colon, and one is RTA. RTA is one of the favorite topic for hypokalemic metabolic acidosis. Okay. Don't be in assumption hypokalemia will always lead metabolic alkalosis. Okay, though there is a mnemonic hypokalemia alkalosis, no, it doesn't happen always. A 75 kg elderly man presented to ER with agitation. He is intubated. On further investigation, he is found to have serum sodium of 165. He started with 5% dextrose. At what rate it should be replaced? What should be the 5% dextrose infusion rate per hour? Is it 100 ml per hour, 125 ml per hour? Based on his hyponatremia, how will you calculate the fluid water deficit and how much of fluid you will replete per hour? Are you guys aware of the water deficit formula? Can anybody tell me the water deficit formula? No?
Sir, 50% of the body mass into the current sodium minus the ideal sodium divided by ideal sodium. We can take ideal sodium as 145. So.
Correct. So now ideal sodium, it's always 140 only. So the sodium value given here minus 140, that is your targeted sodium, divided by 140. So 165 minus 140 divided by 140 into total body water, not body weight. How will you calculate body water?
60%
of the total body.
60%. So 0.6 into body weight. Okay. For male, it is 0.6 into body weight, and for females, 0.5 into body weight. So here his body weight is given 65 kg. Okay. So that's the formula. So see don't go for the answer. See the formula first. Understand the formula. It is a given sodium value minus 140 divided by 140 into total body water. So here the sodium was 165 minus 140 divided by 140 into total body water is 0.6 into 75. The answer will be 8 liters, approximately 8 liters. So out of 8 liters, first 50% given, this is the actual water deficit for this sodium. So you have to correct the 50% of water deficit in first 24 hours. So 50% of 8 liter will be approximately 4 liter. So if you divide 4 liter by 24 hours, the per hour infusion will be approximately 160 ml per hour. So 160 ml per hour is the correct answer. D is the right answer. Okay. You won't remember everything in one shot, but go through this. You should be able to understand. You should be able to calculate water deficit. You should be able to calculate the salt deficiency, what should be the correction rate and all. Okay, how much of hypertonic saline you need to give, that also you should be calculated, but that needs extra bit of effort. So because of the time constraint and all, unlikely to get calculation of regarding how much of hypertonic saline you need to give. But water deficit, please remember the formula is short, and if you are well versed with it, you will be able to calculate within a minute. Next question, last question about A type. All of the following are causes of hypophosphatemia except
E, acute respiratory alkalosis.
Any other answer? The answer is B actually. Okay. Hypophosphatemia usually secondary to malnutrition or alcoholism. Acute respiratory alkalosis does causes hypophosphatemia. DKA itself will cause hypophosphatemia, as well as DKA correction will cause hypophosphatemia. Both will cause hypophosphatemia. Excessive diuretic use, vomiting, gastric loss, both can cause hypophosphatemia. Refeeding syndrome, as we already discussed, it always causes hypophosphatemia. Refeeding syndrome, it causes Hypophosphatemia. So hypophosphatemia in critical ill may lead to cellular dysfunction, skeletal muscle weakness, neurological symptom ranging from confusion to coma, respiratory muscle insufficiency, and neuropathy. Till now, all of you are with me. Any doubt? The speed is okay?
Yes.
Or
Okay.
Okay, because we are 10 minutes behind than the expected thing, but I did cover 16 questions in 1 hour. We started at 7:10. Okay, so I'm just not rushing with the question and explanation. I'm trying to give you the peep into the other options also. Okay, so should we go ahead with type K?
Yes.
Okay, yeah. Type K, you will get 4 options. If you get all 4 right, you'll get 1 mark. If you get 3 right, 1 wrong, you'll get 0.5 mark. Trust me, even 0.5 is important. Okay, if I'm saying that, that means it is very important. The reason for that, one of my junior failed EDIC 1 just by 0.5 mark. Okay, the thing is that it happened in April session last year, not last year, this year only. Okay, not this year, last year, I'm sorry, last year the cutoff was 57.5 and he got 57. Okay, so it was too bad for him to lose the exam just by 0.5.
So how many marks we get for K type?
See, when you can mute yourself because I'm getting echo. Okay, yeah, I'll answer that question. So the K type, if you get less as possible, that's always better. I always love A type because the probability of getting it right in A type is always better. So when it used to happen on on-site basis. So the Indian center was Kolkata. So before 2020, there were approximately 60-40 was the ratio. Okay, but for last few years, in last 2 or 3 years, the ratio has gone down. The K type has reduced to drastic extent. I was lucky when I appeared in 2021, the K type questionnaire was just 16 for me. I got 84 A type and just 16 or 17 K type. Okay, but before that there used to be 35 to 40 K types. So nobody can give you the exact number how many K types, but be prepared. Approximately 30 questions can come. If it is less than that, good for you, because it is difficult to score in K type. The problem with K type, even if you know 1 or 2 options, you need to know all 4 options. Okay, whether it is true or false, you need to be very sure before answering those 4 options, and you always get one or other wrong. So, and when you go into K type, the time is already limited. You are already rushing through the questionnaire, so you don't have much time to think. So in a hurry, you do answer a possible correct answer also wrong. So time is a one problem in K type, and understanding the each option is also other problem in K type. So if you are lucky, you will get just 20-25. If it is tough luck, you may get around 30-35. Okay, it
Marks
used to be there. Yeah.
How many marks, sir? How much we do get? If we get 3
that's
correct.
what 30-35 questions means, 30-35 marks approximately. Okay, each question will have 1 mark. Okay, and the cutoff will vary on the top based of the topper. Whatever the topper is there, based on that they will decide cutoff. So there is no exact no cutoff for each session. The cutoff will vary. Sometimes it will be 50. The cutoff varies between 55 to 62. Okay, the cutoff varies between, sometimes it can go up to 60 to 63. So if you want to be in a safer range, you always try to score above 65. Okay, till now the highest cutoff has gone up to 62, if I am not wrong. Okay, never gone above 62. So those who are in the range of above 65, they get through. Okay, so when you are giving mock tests, when you are trying to solve your questions, try to be in the range of above 65. Okay, that will be the safe range. Let's start with the type K. With respect to tumor lysis syndrome, what are the options are true and what are the options are false? So it will be confusing to listen true, false, true, false. You can type your answer like in a sequence, true, true, false, false, true, false, like that. If you want to answer, go one by one. will increase the bit. I have 11 questions of K type. We can finish it off in another 40 minutes. High dose intravenous steroid therapy is reasonable initial treatment option. Is it true or false? Do you give steroid in tumor lysis? It's false. Clinical TLS can be diagnosed with a seizure and appropriate life findings. Is it true or false? Go one by one. Answer. Everybody is silent. At least type or just unmute yourself if you are going one by one option. Is it true or false?
True, sir.
True. Okay. Okay. A is false. B is true. What about C? Increase
True,
serum calcium and potassium level by 25% is the hallmark. Is it true?
True, sir.
Sir, hyperkalemia.
Yes, hyperkalemia is there, but what about calcium? See the calcium. See, they play with English also. Don't be in a hurry. See, this is the greatest good example of rushing through the options when you have limited time. You see hypocalcemia. You don't see hypercalcemia, right?
Yes, sir.
So C is false. Allopurinol is the treatment of choice to prevent AKI. True or false? What do you use? Huh?
True, sir.
True, false, both. One said true, one said false. It's false. We use raspberry case. Okay. So among 4, only B is right. All other are false. Okay. Only B was right. Other 3 were false. So I have formulated a discussion in such a way that we discuss one by one option. So tumor lysis is life-threatening. It usually seen in a hematological malignancies. Okay. Okay. So hypocalcemia is the hallmark, not hypercalcemia. And ionized calcium will form because with the phosphate. Other laboratory findings, there will be raising more or less. You should be very through with the laboratory abnormalities in TLS and rhabdomyolysis. Okay. One or other question can come in some way, or either in A type or K type. Drug acting to prevent formation on uric acid like allopurinol does increases but doesn't have a role in prevention of AKI. Steroids have no benefits. IV fluids and raspberry case is the treatment. But if I have an option of 2 and I have to choose one best option for a treatment of tumor lysis, what will be? I have given, like, there are 2 options given, IV fluids as well as raspberry case. What is the next best step? What will you choose? Will you choose raspberry case or IV fluids for tumor lysis?
IV fluids.
Yes, it's IV fluids. Yeah, good, correct. Causes of hypercalcemia. See, we solved one A type question regarding hypercalcemia. What does loop diuretics do to hypercalcium?
Sir, thiazide they cause hyper.
So loop diuretics is a false, right? Yeah, so A is false. What about men type 2?
True, sir.
See, type 2B again. It's not a men 1 or men type 2A. Men 1 and men type 2A will have parathyroid hyperplasia. Both will cause hypercalcemia, not type 2B. Okay, that is again false. Hyperthyroidism, true or false?
True. False.
False. True, false, both I heard. It is actually true. Not only hyperparathyroidism, hyperthyroidism also can cause hypercalcemia. Immobilization, pretty easy.
True.
Does it cause hypercalcemia?
True.
True.
Yes.
It is true. Yes,
True.
immobilization causes hypercalcemia. Yes. So C and D is a true. A and B is false. Okay, that's the answer. A, B false, C and D true. So the commonest cause of hypercalcemia is a primary hyperparathyroidism due to parathyroid adenoma. Okay, and as a part of men syndrome, men 1 and men 2A, not 2B, men 1 and men 2A will cause hypercalcemia. And malignancy, sarcoidosis, we are all aware hypercalcemia. Other rare causes are like vitamin D mediated thiazide diuretics, as you said, theophylline toxicity, lithium toxicity, vitamin D excess will cause hypercalcemia. Immobilization is a rare cause, but yes, it can cause hypercalcemia because of the excess bone resorption. Hyperthyroidism it is a recognized cause of hypercalcemia, though less common than hyperparathyroidism, but yes, hyperthyroidism does causes hypercalcemia. Raise anion gap metabolic acidosis causes. True,
Renal
false, true, false.
True,
So,
sir.
yeah, true. Lactic acidosis.
True, sir.
True.
A, true, B, true. C,
False.
False.
very good. D,
False.
very good. All other people agree?
Yes.
See, I want proactive interaction. I'm hearing 2 or 3 people noises. Okay, rather than echoing, please answer. Okay, let it be healthy discussion. Even if you get it wrong, doesn't matter here. Okay, but you'll be sure what is not the answer. Okay, so A and B is true, C and D is false. Yeah, so this table I have deliberately added. If you want, you can take a screenshot of it. Okay, these are the most commonest, or there are multiple mnemonics. Mud piler for high anion gap metabolic acidosis, and one more mnemonic for non-anion gap metabolic. If you remember that, that is also good enough, or this is also good enough. So all these are the most common, most important causes for high anion gap and non-anion gap metabolic acidosis. Okay, so yes, A, B true, C, D false. In renal failure, there is a failure to excrete unmeasured organic acid, so, and lactic acidosis will cause high anion gap metabolism. Pancreatic fistula, because of the bicarb loss, there will be non-anion gap metabolic acidosis. Urinary diversion, everybody is aware of that, because of the chloride ions, the bicarbonate will get exchanged, and that will lead to non-normal anion gap metabolic acidosis. 36-year-old woman admitted with a severe urosepsis. Blood pressure was 86/52, pulse was 112, temperature was high, 39.8. Her initial lactate was 5.8. She received 3 liters of normal saline as a part of her fluid resuscitation. The lactate has reduced to 3.9 from 5.8. What are the statements correct, true, and false?
A is
First
false.
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 A
False.
false, B
B true, sir.
True.
true, C
True, sir.
Mm.
there is an English language trick in that. It's a 15-20 millimole per kg, not a 15-20 millimole per kg per day. It's not 15-20 millimole per day. Okay, so that is false. D,
True.
again English, see all these international exam, whether be it MRCP or EDIC, they do play with your English. Okay, so see what, read carefully. Lactic acid is produced by the metabolism of lactate dehydrogenase. What do you think? Lactate dehydrogenase?
So it is
It's an
a product
enzyme,
of
it is not a product. Yeah,
Yes.
correct.
False.
It has
false.
false. Lactic acid is being produced from pyruvate, not and the catabolic enzyme is the catalyze is a lactate dehydrogenase. Okay, so A is false, B is true, C is false, D is false. So correct answer only B is true, all other are false. Okay, lactate is mainly cleared by liver around 80%, and though the kidney and skeletal muscle contribute, but it's just 10 to 20%. There are 2 types of lactic acidosis, type A and type B. Type A is because of the hypoperfusion, anaerobic metabolism will occur that will raise lactate. That is a type A lactic acidosis. So in this case, there was a hypoperfusion, hypotension, so the type A was the correct answer. Okay. Type B, most common cause for type B lactic acidosis is a underlying liver dysfunction. The other causes could be drugs, malignancy, and mitochondrial dysfunction. Normal production of lactate will be 15-20 millimole per kg per day, not 15-20 millimole per day. Okay, that was a trick there. The value, the numbers were correct, but it was not per kg. So that's why be careful about the English also. In K type, they usually play with English. In A type, you have ample time. In K type, you rush through the options and you usually miss. And even if you are supposed to get 1 mark, you will lose 0.5 or 1. Lactic acid is derived from the metabolism of pyruvic acid, pyruvate, and this reaction is catalyzed by lactate dehydrogenase. Regarding hyponatremia, what all are true, what all are false?
That is documented for less than 48.
So first is true.
First is true. A is true.
True.
Okay, A is true. B.
True, sir.
Also true, sir. Hypotonic hyponatremia with normal ACFO.
Yes, sir.
Okay, normal with a like euvolemic hypotonic hyponatremia. Correct. A is true. B is true. What about C?
C is false.
False.
C is false. What is the correct rate of correction? So 1 ml per hour.
0.5 millimole.
Yeah, 1 ml millimole is a wrong. So 0.5 is a correct.
0.5.
Yeah. D. What is it?
They should be attributed to electrolyte. Reduction of hyponatremic factors fail. Symptoms fail to resolve. They should be attributed.
So I have played with the English here, but think.
Following correction of hyponatremic symptoms failing. The result immediately should not be attributed to doctor or disturbance.
You don't have much of time.
False.
You are taking too much of time. Yeah, you are trying to understand the statement. Okay, they have played with your English. You're trying to understand the statement. Had it been yes, if the symptoms doesn't resolve, that doesn't mean the cause was hyponatremia. If had they presented in a simple sentence, it would have taken less time. But the one understanding from this sentence is, if the symptom doesn't resolve after correction of hyponatremia, does that rule out hyponatremia for the cause?
No.
No. Sometimes even after correction of sodium, the symptoms do not recover immediately. It takes time, but that doesn't rule out hyponatremia. Okay. So the correct answer is A and B. A and B is true. C and D is false. Just a moment. I'm just getting a call. Hello. कितना है अभी? ओके, ठीक है, चलो। यूरिन आउटपुट ठीक है ना? Okay, sorry. So 48 hours is a threshold to differentiate between acute and chronic. SIADH, it causes hypotonic hyponatremia with a euvolemia. Sodium correction, it's always with a 0.5 ml per hour. And the target, so what's the target sodium in first 12 hours, first 24 hours? How much sodium you will raise in first 24 hours? What's the cutoff for highest?
It's 1 to 2 milliequivalent.
No, in 24 hours.
10 to 12 milliequivalent.
If the sodium was 112, in next day morning, how much sodium you would target?
120.
Up to 8.
Up to 8. Yes, correct. 8. See, okay. Some people argue we will want 10, 12, but 8 is a safe. Okay, 8 is a prefer, and if that is the question, please go ahead with the 8. What is the risk if you overcorrect?
Demyelination.
Myelinosis.
Yeah, ODS, osmotic demyelination. DKA treatment can lead to
Hypomagnesemia.
A is
True.
B is true.
Hyper is false.
C is false. D is true.
And hyperchloromic acidosis true.
Okay, so D is true. Everybody will agree. C, many people said false. Every other people agree to C false.
D is false. Yes.
Okay, D is true. C false. A and B true or false?
True, sir.
Yeah, true.
A true, B true. Good, very good. So only C is false. All others are true. Okay. So hypoglycemia is a common, may result with insulin overreplacement. Magnesium and phosphate will fall during early treatment because of the intracellular shift. Cerebral edema mainly occurs. Usually it happens in children, but even it can happen in adults also. So you need to you keep watchful regarding the GCS and over fluid resuscitation. Okay, and over sodium correction also. Hyperchloremic acidosis with a, okay, I'm sorry here, it is a normal anion gap. Okay, So it's not high anion gap. Hypercholemic acidosis is normal anion gap metabolic acidosis.
Correct.
Yeah,
Yes,
it's not high anion gap. It's a normal anion gap. Sorry for this error. Let me correct it.
Vegetables.
Yeah.
Okay. May occur as a consequence of excessive saline. The following are recognized causes of isotonic hyponatremia.
Hyperglycemia, true, sir.
Okay.
B is false.
A and C true.
C is
A
also
and
true.
Okay, A and C true.
B false. E true.
B false. B, what will happen in B? Will it be isotonic or hypotonic?
Hypotonic.
What will happen in
hypotonic.
Addison's disease?
Addison's also hypotonic.
Hypotonic, correct. Addison's, SIDH, Beer proteinemia, all three will cause hypotonic hyponatremia. So A and C is right, other all false. Okay, yeah. So the majority of patients hyponatremia is a hypotonic, but in rare cases, like hyperglycemia, mannitol infusion, glycine absorption will cause, during the prolonged urological surgery, will cause isotonic hyponatremia. Okay, SIDH and cerebral salt filtering, hypoadrenalism, Beer proteinemia, all will cause hypotonic hyponatremia. The following are recommended initial treatment options in the management of severe symptomatic hypotonic hyponatremia of intermediate onset.
Yeah.
A is true.
Sorry, not intermediate, indeterminate onset. You are not sure about acute, whether it is acute or chronic. Okay, but he has a symptomatic hypotonic hyponatremia.
A is true.
Okay, Desmo.
This movie false.
False, sir.
Okay, 𝐿-𝐴𝒃𝒛.
False.
Do we use in acute scenario?
No, sir.
No,
False. Chronic.
Okay. Demiclocycline.
True.
That was false.
False.
Good, very good. So good. I thought you guys will have some tough time with K-type, but you guys are doing very good with the K-type. So I'm proud of you. But in actual exam scenario, it gets tricky sometimes. So it is not difficult, but the time limitation. So if there are, what I used to do, what I did for my exam, it was online exam. So I checked how many K types and how many A types are there. So I had some 16, 17 K types. So I kept some 2 minutes per question for K type. Okay, because each question will take some extra 10 seconds in K type. So always keep 2 minutes per question. So if there are 20 questions of K type, always try to keep 40 minutes for those K type. You'll have if you have 10 extra seconds, you will read through each option. See here, you guys are getting almost right of all the options because you are reading each options carefully and thinking through it if it is tricky thing. Okay, so that's the only important point when you are trying to solve the K type. There won't be too much of theory required for K type, but if you can read what is given in the question stem, if you can think through the options, if you have that 10-20 seconds extra, there is a high chance you will score more in K type also. Okay, so that strategy I use. I kept 10. See, you have to solve 100 questions in 180 minutes. So if you calculate that way, the per question you get less than 2 minutes. Okay, you get 15 seconds less than 2 minutes for per question. So try to manage your time in such a way that you should be able to finish up your A type bit earlier, and you should be able to keep 2 minutes per question for K type. So one of my seniors suggested me that strategy. I would strongly advise you, if you want, you can try that strategy in mock test. If it is helping you, please consider. Okay, so the answer here, A was right, all other were false. So hypertonic saline is advocated. It will give adequate 150 ml adequates of 150 ml and try to increase the sodium as as early as possible to 5 millimoles. If it is 112, you will try to reach 117 or try to resolve the symptoms. Okay, but still the correction won't be more than 0.5 ml per. Yeah. Okay. So there are clear recommendation against the use of demeclocycline and vasopressin antagonist in case of acute symptomatic hepatitis. Desmopressin is a I'm getting some disturbance. If it's possible, can you mute? Okay. Desmopressin is a synthetic ADH utilized in the management of DI. Okay, that is used for a hypernatremia, not hyponatremia. If you use that here, that will work further worsen hypernatremia. Acid-base balance. What are true? What are false?
Plasma pH is equal to intracellular pH. True. A is true.
Okay.
Ink is strong and indicates an alkalosis.
Okay. A is actually false. It's not equal. What about B? SID. Increased SID will cause alkalosis or acidosis. SID not. SID is for. Huh?
It will cause acidosis. Indicate B indicate acidosis.
Decrease SID will cause acidosis. Yes.
Alkalosis.
So it is a true. Increase SID will cause alkalosis. So B is true. A is actually false. What about C?
True, sir. It will be
true. It will be true.
True. If B
Yes,
is true, C is true.
B is true, C is true. And what about D? Acidosis.
True.
Yes. They have played with your English. They please understand. See the D option. It's the question of English, not the question of critical care.
Is an increase in hydrogen content.
Acidosis is defined as an increase in hydrogen ion concentration of the birth. Is it acidosis or acidemia?
Acidemia.
It's a false. Okay, so B and C is true, A and D is false. So regarding last option, the correct term to increase in a hydrogen ion concentration is a acidemia. The process is called acidosis or alkalosis, but the terminology for that is a acidemia, alkalemia. Okay, not acidosis or alkalosis. Plasma pH, there is a difference of 0.6 pH units. SID, as I said, if it is increases, it will cause alkalosis. If it decreases, it will cause acidosis. So renal failure always cause acidosis. So definitely SID will decrease. Okay. The osmolar gap and anion gap. What are true? What are false?
A
is true.
Methanol poisoning tends to present initially with the increased anion gap. Okay. B.
True.
Okay, normal, true, correct. The anion gap is increased by unmeasured anions.
True.
True.
Correct.
Yeah.
B is true, C is true. What about D?
D is also true.
Yours
D is
true.
also
Should be correct. Right.
correct. Very good. Okay. A was false. Why? Initially, how methanol poisoning presents? Does it present with the again, this is about English. They increase methanol poisoning is one of the cause for high anion gap metabolic acidosis. We are not talking about high anion versus non-anion. We are talking about what presents first in methanol. Is it osmolar gap, high osmolar gap first, or high anion gap first?
Osmolar gap.
Osmolar gap first. Okay. So methanol poisoning causes increased osmolar gap initially due to toxic alcohol. Later on, it will lead to high anion gap as well. But the first thing, if it is initially, that's why sometimes, if you can argue that they have asked what will present first and what will present after, but it is their answer. You cannot say this is wrong or right. So that's the answer. That's the answer. Okay. So that's why A is false. B, C, D, everybody got it right. Everybody had the correct thought process. The anion gap is increased by unmeasured anions. What are the unmeasured anions? Lactate, phosphate, and sulfate. And you will always correct anion gap to the albumin level. Please remember the this formula as well. How will you calculate the corrected anion gap for the low albumin? How will you calculate correct calcium for low albumin? How will you calculate correct sodium for hyperglycemia? Okay. Please remember these three formulas, and I did not cover this thing in theory, but these all are important. Okay. High anion gap correction for an albumin, hypocalcemia correction for low albumin, hyponatremia or hyponatremia correction for high sugar. Okay, please correct that. There is a formula for that also. Last question, we are on time. Action of magnesium sulfate on neuromuscular junction can be described by the following.
A is false.
Okay.
B is true.
See, hypomagnesia will cause what? See, magnesium and calcium will work hand in hand. Okay.
C false, D true.
D true. Here you guys got it wrong. Okay. So only D is false, all other are true. Okay. The reason for that, magnesium sulfate competes with the calcium ions. Okay. It competes with the calcium. So calcium helps you to release the acetylcholine. So because it's competing with the calcium ions, calcium channels, it is actually decreases the acetylcholine. Okay. So it does inhibit the release of acetylcholine at a NM junction. Regarding B, magnesium reduces the dose and time of onset of neuromuscular blockade of depolarizing drugs like a 𝐿-𝐴𝐴 and rocuronium. Okay, NeoVac or atracurium we use, all are depolarizing drugs. Okay, it actually increases the it decreases the time of onset and it actually prolongs the duration of action, but it exactly happens opposite to the succinylcholine. It is a non-depolarizing drug. It actually decreases the duration of action because it actually accelerates the hydrolysis of succinylcholine. Okay, so if you go think about option D, it actually decreases the duration of succinylcholine, but other A, B, C are true. Okay, you can read this explanation. That's all. Any questions till now? What we have solved? We solved 16 questions of A type, 16 or 17, and 11 questions from K type. I wanted to cover 30 questions, but I could not prepare other 3-4 questions. Sorry for that, but we are on time. So like any doubt, any tips you wanna discuss, we can discuss it here. Or you wanna guys close it, we'll close it.
Sir, please provide me the formula for correction in hyponatremia along with that is the for calcium hypercalcemia.
For sodium correction in with relation to sugar. Yeah, so for just easy purpose, we calculate 200 minus like sugar minus 200 divided by 2. Okay, so if sugar is 400, so 400 minus 200, that will be 2 divided by 2. So it will be, the answer will be 2, right?
Divided by
100,
2.
sorry, divided by 100. I'm sorry, divided by 100. Okay, sugar level minus 200 divided by 100. So if it is sugar level is 400, minus 200 will be, so 400 minus 200 will be 200 divided by 100, that will be 2. So you will increase the sodium by 2. The corrected sodium will be 2. Regarding the calcium, corrected calcium for albumin, every 1 reduction of albumin we have to raise calcium by 0.8. If the albumin is 3 instead of 4, the normal level for albumin is 4. If your albumin is 3, so that means you have to add 0.8 of calcium. So if your calcium is 7, so your corrected calcium will be 7.8. If your albumin is
7.8.
No, I did not understand. Hello.
No, I
did you understand the
maybe
I'm sorry.
Connection.
So the calcium correction, every So every one decrease in albumin, we have to raise the calcium by 0.8. Okay, if it is 3, you will raise the calcium by 0.8. If albumin is just 2, you will correct the calcium by 1.6. If it is 7, that will be the corrected calcium will be 1.6. Okay, you can just Google all these formulas. For the sodium also, it's not exactly the same what I said, but for practical purposes, this is what I use. But for the exam purpose, try to use the exact formula. That okay, it's always beneficial. Okay. That's all. Yeah, somebody in the chat, important difference between TLS and rhabdomyolysis. Yes, the electrolyte disturbance is more or less same, but the cause for the condition is a peculiar. In rhabdomyolysis is different. The TLS, there will be always malignancy. After chemotherapy, it will happen. Okay. The treatment, the primary treatment will be always IV fluids. Drugs here in TLS, you do give raspberry-case. Here in rhabdomyolysis, you alkalize the urine with the bicarbonate and all. And in both the scenarios, if the electrolyte abnormalities are getting worsened, if the AKI is getting worsened, you consider dialysis. Okay. The differences, if you ask me, it's a etiological difference is more important. Okay. Otherwise, the electrolytes abnormalities are more or less same. The etiology is different and treatment is little bit different. Okay. Okay. Thank you.
Okay, thank you.
Thank you.